Hi, I'm Raym Geis, and for this clinical data analysis session, we're going to talk about data distribution shift in radiology. If I trained it correctly, the distribution of my model's predictions and the distribution of ground truth data overlap very carefully. But no matter how good that is, over time, the distribution of ground truth and what my predictions are drift apart. That occurs because the data relevant to the model change over time and setting, and that causes these values to drift apart from each other. Let's suppose we're going to build a model to try to find Waldo. Here he is. So here's Waldo, and then using that we make a well-curated data set of Waldos. If I train with this, with lots of features to find Waldo, many of them distinctive, I'm going to have a great algorithm. It's going to find Waldo probably better and faster than doctors. Suppose I want to find things that are Waldo-ish, however. I'm going to get a distribution of things that I need to identify. Well, then I need a new type of training data set that has a wide distribution of things, maybe different sexes or ethnicities, or perhaps sometimes the data doesn't include everything that I initially had with Waldo, or different ages. If I'm going to be viewing a data set in the future that has a lot of old people, I want to make sure I'm training with some old people or young people. Then I have to make decisions about things like what happens if you have some features that you might say are Waldo-ish but are obviously not Waldo. Those are all decisions that have to get made, and then as I'm seeing things in the future, I'm going to have different distributions of these things, and probably things that I've never seen before, such as a disease that pops up like COVID, where my model has never been trained on that. And we're starting to learn that in radiology, it's sort of like this, where if I asked everybody in the audience to draw a Waldo, they're all different, and sometimes our machine is good at picking them up and sometimes not, but this is a wide distribution, and this distribution changes over time or setting. Different kinds of shift, and in radiology, covariate shift, or the change in input data, is one of the biggest ones. You're going to have changes in the attributes of your population, or the disease prevalence, or how the anatomic appearance of the pathology changes. When you're training things, you need to have labels that go with the images, and sometimes the labels vary depending on, say, the labeler's expertise or the policy. And one of the big ones for us is acquisition shift. Let's talk about that one. So acquisition shift in radiology, something has to acquire the pixels. And every imaging machine has its own unique pixel data distribution because each machine acquires the pixels slightly differently. Let's use CT scans for an example. The CT makes a slice of the patient, and that slice is made up of a whole bunch of little pixels. Each one of those pixels is associated with a density called a Hounsfield unit, and how those pixels are generated and the resulting Hounsfield units varies dramatically from machine to machine. One of the biggest causes for that is differences in protocol, and protocols are the settings for each variable that a machine uses to acquire or process the image data, and then turn those data into images which are pleasing to humans. Here I'm listing 5 different CT scanners, which all are trying to generate images that are appropriate for screening for lung cancer. And if you look, none of the settings on any of these machines is exactly like any of the other machines. Over on the left are some of the different things that I can protocol. I can say, oh, this is how I want the machine to run. And I'm doing it subtly differently on each one based on the attributes and abilities of the machine and how I want to generate the images so that they look good to me with two human eyes. Here's a CT machine with cover off. It's a hugely complex machine. So what's happening is the thin X-ray beams get generated on one side and they shoot through the patient and get detected on the other side. And the machine rotates very quickly so that you've got these beams of radiation shifting through the patient as the patient goes through the scanner. And every imaging machine produces these pixels slightly differently. The machines are just built differently, and the techniques, both the mechanical things and then the programs that they use to acquire them and filter them, are different. If we look at the raw data that comes out of one of those machines, what we're getting are these little linear lines that are sinusoidal almost, and you put those all together and you get what's called a sinogram. That's what we have on the left. That's actually the data that we're acquiring. Then each machine takes this crazy spirally looking thing and does what's called reconstructions. And at that point, what it's trying to do is reconstruct it with mathematical formulas to make with the goal of making the images pleasing to two human eyes, and also to demonstrate the pathology as well as possible, such as here where I can see a small intracranial hemorrhage circled. But I also want to have the brain parenchyma kind of look pretty to two human eyes, or the bone to be just right, which is that white stuff around the outside. Each type of CT scanner, each company has a different sets of filters and magic that they do to try to make the images look pretty for people. We talked a little bit about label distribution. So when you're trying to train one of these algorithms, you need the images and then you need labels if you're doing supervised learning. Now, the ideal labels are consistent, accurate, and reflect the truth of what's going on. But in reality, these labels are noisy and they change over time and setting, either because we get new concepts about the diseases, or the disease itself changes, or there's maybe the people who are doing the labeling, they just change their mind, or they have different levels of expertise. Here's an example of fuzzy or noisy labels with ground glass opacity. Now, ground glass opacity is sort of that haziness, kind of the light gray that you see in the lung here on a CT scan. Suppose a bunch of us are labeling this. All of us are going to label this light gray stuff as ground glass. And this dense white stuff, we radiologists call that consolidation. But what about this? Well, it turns out that some radiologists call that ground glass, some call it consolidation. So what you end up with are these distributions of labels. And there's overlap, and definitely places where some people say, oh, this is ground glass, other people say it's consolidation. So that the labels have their own distribution, and that can confuse the model. Again, here are patchy ground glass opacities. This was something that showed up in early COVID, and so people built a lot of machine learning algorithms right at the beginning that were going to, quote, diagnose COVID because they were finding the ground glass opacities. Well, these ground glass opacities existed way before COVID ever showed up, and they have a big, wide distribution of diseases. And one of the things that this happened is called as a fat tail of diagnoses. There are a lot of causes for these radiology findings. Now, prior to COVID, some of the most common causes of this were due to viral pneumonia, or with pulmonary edema, sometimes with pulmonary emboli. But then turns out there are 29 different things that are listed in a differential diagnosis of ground glass opacity. Some of them are incredibly rare, but they're very important diseases and you don't want to miss them. And you don't want to call them, say, pulmonary edema when they turns out to be some sort of other kind of pathology that you really need to treat entirely differently. When we're training the models, oftentimes these rarest diagnoses, we don't have a lot of examples to use when we're training it. And it's not uncommon, especially today, that you don't have any examples of that. And so if the algorithm were to see that, it wouldn't know to call it one of those diseases because those diseases are out of distribution, or OOD. The model has never seen them before. It hasn't learned to recognize them. OOD data is a big deal. Now, it can come because a new pathology shows up like COVID, but more commonly what we see are things like you have overlapping findings. You have two diseases that turn out to cause a finding. Or you have confounding comorbidity. And a good example is patients could have rip-roaring tuberculosis, which normally causes a lot of inflammation, which we see as white stuff in the lungs. But if you have AIDS and are very immunosuppressed, then you can't generate the inflammatory response. And so you might have a normal chest x-ray, but very rip-roaring TB. Sometimes you have erroneous input data. And then there's something called concept drift. Okay, we talked about this ground glass opacity. You have all these things. Nobody's ever heard of COVID, seen COVID, and then all of a sudden, one day, boom, everything's COVID, right? So the concept of what ground glass opacity means, the label that you want to attach to it, has changed dramatically because the concept of what ground glass opacity means changed. Now, what happened with COVID is that though we saw initially lots of people with ground glass opacity, now because COVID has changed itself, most of the patients showing up with COVID don't have ground glass opacities. So, boom, that goes back down. That's called manifestation shift, where the manifestation of the disease changes. COVID's still around, but it's not associated with ground glass opacity as much. So the take-home message today is that in clinical practice, each site's data are different from the data in other places, and it's certainly different from the data on which the model was trained, and all of these data change over time. And because of this, computer vision, machine learning, or AI results, they're unique to each setting. They change over time. Now, they may only be a little bit different in your place than somebody else's, or they might be a lot. You don't know. And how you're going to monitor that things are changing over time, you definitely need to monitor it because, again, you don't know whether it's going to just change a little bit or change a lot. So we've briefly looked at that. It's a complex subject. It really is a thing that's going to have to be addressed by a combination of good, solid data scientists and computer scientists, epistats people, as well as domain experts. And SIIM is the place where all of those people can connect. And I certainly invite you, whether you're in computer science or data science, and you want to learn more about the domain, SIIM is a good place where people want to speak your language. And on the flip side, if you're in the domain and you want to learn more about informatics and machine learning, SIIM is a good place to get that technical background. So thanks very much.